Okay, perfect. So, yes. Well, in case you haven't heard about a clinical embryologist, because we are few in the world. A clinical embryologist is a practitioner that works in the IVF lab, that works with gametes and oocytes and sperm. We are few in the world, and I'm really honored to present this to you because we usually talk to each other in the IVF clinics usually, but do not. We have like a circle, and we know that today what is more valid is interdisciplinary work. So I'm really honored to be here and to be able to present this in a conference of pediatrics. And the first thing that I want to present is some stats for us to have some context on it. I wanted to ask you this trivia. What is the current incidence of infertility according to the WHO organization? Um, and well, it would be 1 in 10, 1 in 6, 1 in 100, or 1 in 20 couples. Um, so maybe it is more common than you think, and we have that 1 in 6 couples have infertility right now. So maybe some friends of you or some acquaintance have infertility and you don't know. So it's really common. Some stats. We have 8 million IVF children have been born worldwide since the appearance of IVF in the world. And we have 2.5 million cycles that are being performed every year. If that results in over 500,000 deliveries annually. And as you see in the table, we have in many countries, we have almost 30% success rate of that treatment. There are some approaches of ART. We have what is known as low complexity fertility treatments and high complexity fertility treatments. The thing with low complexity fertility treatments is that they are cheaper than the high complexity fertility treatments, as they do not need like a infrastructure lab to be performed like the high complexity. So that's why they are cheaper. They just need some medication probably. With the high complexity fertility treatments, we do need an IVF lab because we need to handle eggs and sperm and embryos. They're really delicate. So this is why the cost goes like sometimes 5 times the price of low complexity fertility treatments, and that's really sad because IVF treatments are just for a percentage of the population, just the highest, the population with the highest income. And that's really sad because the accessibility is difficult. Then if we focus on high complexity treatments, we have two types of fertility treatment, but they go with the same process. The first step is egg retrieval. As you see in the presentation, we have on the left the clinician part, and we have on the right the laboratory part. In the clinician part, you see that they have a special needle. This needle is inserted via transvaginal ultrasound aspiration, so it goes in here, it goes directly to the ovary and inserted in the follicle. And then they start extract the liquid, the follicular fluid, and put them in a specific container that is this tube. This tube is then examined to find this type of cell that is the cumulus ovorus. And then there is where IVF starts, where tier ART starts. Here we have a dish where they are put some hours after the egg retrieval. These oocytes are ready to be fertilized. So the two treatments that we have is conventional IVF or ICSI. ICSI, that is the next procedure that I'm going to explain. In IVF, we put the oocytes and then they spontaneously chose there's the sperm that they want to be fertilized by. So we put the sperm in a hole, and the sperm go in like in this. Let me. Okay, this okay. Then the video is reproducing, I think. Yes. Then, yeah, you see in here that the sperm are being put next to the egg. And this is, yeah, this is the pipette where we put the sperm, and the sperm go to fertilize the egg. They're really tiny indeed, and they go spontaneously or naturally to reach the egg. And there is another type of procedure that is ICSI, intracytoplasmatic sperm injection. This procedure, I always remember that, it was born in 1991, where the first ICSI baby was conceived, and then the baby was born in 1992. So it is as old as me. So I always remember that this is the ICSI procedure. It is a more complex procedure, and we need a specific equipment. And it is also technically more difficult to perform. And we need also this microscope that is attached to a micromanipulator, and with a little pipette. This is another video with a little needle. That is the ICSI needle. A sperm is injected. You see here is the sperm inside the needle. It goes inserted directly in the cytoplasm of the oocyte that is held by another needle. So this is a really tiny procedure, but you see in that picture the magnification, right? Difficult to perform because it has, I mean, the oocyte has to be done in a specific procedure. The sperm has to be put in a specific position, sorry. So it's technically really high complexity procedure. Then we got, so we have the two fertilization procedures that I present, IVF and ICSI. Then we got embryo development, embryo culture and development by day 2, day 3, day 5, and day 6. In day 5 and 6, we have the blastocyst. The blastocyst is the cell that we transfer. So here is the embryo transfer. The embryo is put in a catheter and then inserted into the endometrium, directly into the fundus. And well, why do we have a popularity of ICSI now? Why has ICSI increased? Well, first in the left figure, It is called figure 3. We have the two procedures, and we see that IVF is in green, and in blue we have ICSI, and we see that throughout the years from 1993 to 2019, we have a big increase in the number of ICSI procedures in the world. And in the right, we have the ICSI indications. The ICSI is the principal or the main indication is for male factor. We have alterations of the sperm, of the ejaculated sperm, and it is the indication that in which it was born, because in 1991 or before 1991, we used to tell the families that need this treatment, that have male factor, to go home. And after 1992, with Palermo, that was the scientist that first started with it. We have, let me who's here. Okay. With Palermo, we have the first ICSI, and male factor also encompasses epididymal and testicular um, problems with sperm, or epididymal and testicular origin sperm. And we also have indications as non-male factor, for example, oocyte dysmorphism, low number of oocytes. But these are more common now than before in 1991. Here we have two figures. In the left figure, we have a spermatozoa from ejaculated origin, and in the right, we have a spermatozoa from testicular origin. And as you see in the fertilization part, that it has the biggest impact. ICSI has the biggest impact. We see that when we inject motile spermatozoa, that is the column of fertilization in the left, we have a bigger percentage of fertilization rate, and less, and we have less fertilization rate when we have immotile spermatozoa. That's because in male factor, infertility is when ICSI has the more impact. And the same tendency is followed in here with testicular spermatozoa. Okay. Then we have unexplained infertility. Well, in our field, we have two groups of people. In the first one, the diagnosis of unexplained infertility in a couple unable to reproduce is made after excluding common causes of infertility, including male factors, ovulatory disorders, tubal damage, uterine and peritoneal abnormalities. So after excluding all factors of infertility, we say that we have unexplained infertility. But that's one group. The other group says that there is no unexplained infertility. If you have unexplained infertility, maybe is that you haven't had a good diagnosis, that you haven't have an exhaustively diagnosis. So maybe something is missing. But the truth is, one common point is that the approach to unexplained infertility is from conservative to more invasive interventions. So as you see in the triangle, you have a intrauterine insemination in the baseline. That is the first line of treatment. And then after that, you have IVF and ICSI procedures that are, as you see, ICSI is in the top of the triangle, so is the last chosen alternative. Sometimes algorithms of treatment are based on duration of infertility and parental age. While IUI represents a simple, inexpensive approach, and is the first line, it does not allow a complete understanding of still reasons for the inability of the couple to reproduce. Then, therefore, when IUI failed, the utilization of ART seems reasonable to investigate issues related to fertilization and embryo development. We have a bigger scenario with ART. So for some people that are diagnosed with unexplained infertility, sometimes because of depending of the time of infertility, for example, 5, 6 years, uh, couples go directly to ART and do not go to IUI. Sometimes they go directly to ICSI. And one study selecting couples with unexplained infertility and that failed IUI and were subsequently treated by ART, both by IVF and ICSI, concluded there was no difference in fertilization rate and embryo developmental quality between standard in vitro insemination and ICSI. And the same conclusion was reached in a prospective randomized trial on 60 women with unexplained infertility. The only advantage of it, it is a potential psychological benefit for the couple. Well, personally, I do think that IVF is a really emotional treatment because the load of emotional matters in this treatment is really high. But with IVF, conventional IVF, that was the first technique that I explained to you. There is a 6.7% of fertilization failure, and to explain a fertilization failure to a couple is really difficult because that could mean that you don't use ICSI for them, but that's there's a reason why clinics use IVF, conventional IVF before ICSI, and this is why. Well, this is why. No, it's the same. The next slide where I'm going to explain that why. Routine ICSI, routine use of ICSI versus exclusive for male factor. Well, you see in this table, ICSI is widely considered the preferred method to level consistent fertilization and prevent fertilization failure. Many studies have documented the increasing use of ICSI worldwide, but huge national differences are presented. And in 2000 and in 2016, ICSI was the most common type of ART treatment in all Europe. You see, in most northern European countries where ICSI is primarily performing male factor infertility, or in cases of fertilization failure, the use of ICSI had been steadily at approximately 50% of all treatments, in contrast to a very high use of ICSI in southern Europe, with some countries having an ICSI rate of approximately 100% of their ART treatments. You see, here we have, for example, Spain, where the use of ICSI is really disseminated, and the use of IVF is really poor, in contrast to northern European countries that do not present this tendency. And so there's higher adverse perinatal outcome using ICSI or choosing ICSI as the primary option. There was no significant difference in the risk of stillbirth between children conceived using ICSI versus IVF. So the risk of stillbirth is practically the same. However, there were more stillbirth using ART, both ICSI and IVF, compared with children conceived without medical assistance. But the risk of malformations using ICSI, indeed, among singletons conceived using fresh ICSI, 6% had a major malformation compared with 5.3 of children conceived using fresh IVF. 4.2 of children conceived without medical assistance, and 4.9 of children conceived using cryo-ICSI. And then when malformations were grouped by different organ systems, children conceived using ICSI had a higher risk of respiratory and chromosomal malformations compared with children conceived using IVF, but there were very few cases in each group. So that's it. To conclude, the utilization of ART help us investigate issues related to fertilization and embryo development that we cannot see with low complexity treatments as IUI. We can hypothesize that the tendency to increase the number of ICSI versus IVF fertilization in cycles is due to logistical and administrative reasons rather than clinical decisions. And this information is of great relevance to the pediatric scientific community, not only to understand the differences between reproductive techniques, but also their implications for future diagnosis, screening, management, and of course, long-term follow-up of affected children, as well as considering for their families. Moreover, this knowledge can help shape public health strategies aimed at improving surveillance of these increasingly common conditions driven by the growing use of ART and ICSI in particular.